Whenever you see a terrible triad or an elbow dislocation with some fracture associated, immediately think of three columns. The lateral column would be the radial head, the lateral ulnar collateral ligament, and the common extensor origin. So it will be in this area. The anterior component or the anterior column would be the coronoid and the capsule. So it would be the coronoid and the capsule. And the medial column would be the medial collateral ligament. That would be the anterior band of the medial collateral ligament. And it's quite close to the coronoid process, and the importance of which we'll talk about it in a bit. So for me, whenever I manage a terrible triad, I would always look at these three columns and assess them one after the other. So why is terrible triad so important? Honestly, it's a very uncommon injury. Over 6 or 7 years, our data showed we just had about 22 cases amongst many elbow dislocations that everybody sees. However, because elbow dislocation, a simple elbow dislocation is so common, I think a terrible triad could be missed. For example, in this scenario, the concerned surgeon thought this was an elbow dislocation, reduced it, and tried to pin it because he was unable to keep it stable. And the right side x-rays are at about 1 year from the day of surgery. So the terrible triad is missed because we have an incomplete clinical assessment. That's what probably happened, because the surgeon would not have looked at the stability of the elbow after reduction. There would probably be incomplete imaging and probably an inadequate surgery. The consequences of missed terrible triad are quite bad. For example, in this case, this is a significant osteoarthritic elbow in a young patient. You have unstable elbows, you have arthritic elbows, and you have stiff elbows. So it's essential that we don't miss a terrible triad. Remember the three columns. So the anterior column is primarily the coronoid. So in sometimes after you reduce the elbow dislocation, you may not see a coronoid fracture. So don't say that this is a simple dislocation. Even if you don't see a coronoid fracture, it could mean the second component is injured. That's the anterior capsule. It could be either avulsed or it could either be ruptured. Commonly, you see a coronoid which is like this. It's comminuted, or there could be a big piece. Here, yes, we are definitely alarmed that something is wrong with the elbow. It's this picture that concerns me, because this is the picture that could probably fool a surgeon in doing something differently. On the radial side, the lateral side, you can have a radial head fracture, which is quite common. It could be a comminuted fracture like this, or it could be a neck fracture like this. Again, don't be fooled by this image. Whenever you see a fracture around the elbow, start thinking about, am I looking at a terrible triad? And we will see how we can assess it. So this is the common sequence that happens. You see a picture like this in the clinic or in the ER, then you kind of do your close manipulation and you end up getting the elbow back. All right. And this is a fairly common sequence and everybody knows how to reduce the elbow. For me, if I find it easy to reduce, like if the elbow just flops back in place, it can very easily flop back out. So for me, how I reduce the elbow, whether it was a little tough or whether there was a clunk of reduction, immediately puts up my antennas on whether this is a terrible triad. So the ease of reduction should be your first guide. Now, everybody knows you have reduced this dislocation. Looks quite simple, innocuous. You have reduced it, and then you have put it in a splint, and you've gotten an X-ray. Look at this X-ray first. You draw a radial axis through the radial neck, and it bisects the capitulum. So I know that the radial head is aligned with the capitulum. If you look at the ulnohumeral joint, it's fairly congruent. Now look at this X-ray. I'm going to draw a radial axis, and it is falling behind the capitulum, and there is slight widening of the ulnohumeral joint. So now I know, despite having a reduction of the elbow, the joint doesn't look good, and this should immediately be a red flag of whether this is an elbow which is unstable. Look at this position. This is 90-degree elbow position, and still the elbow is subluxated. So the first thing was the ease of reduction. The second thing was anything with the X-ray after reduction. So you have reduced the elbow. The second important thing is to check for stability. And the stability could be checked with the patient in the lying down position, and ask the patient to flex and then gently extend. If the elbow seems to dislocate or subluxate out even before it reaches a 30-degree extension, it's a significantly unstable elbow and we need to do something about it. The next step would be to give an above elbow plaster for immobilization. I usually do it at 90 degrees in flexion and in pronation of the forearm. X-rays in the plaster are important, like we discussed earlier. For any elbow which I find or suspect to be unstable, I would always do a CT scan. It's quite essential because you might pick up a slight subluxation of the elbow, which we may not see on an X-ray. This is an obvious dislocation, but you could see a small subluxation. You could also see a small chip fractures of the coronoid, which you may not see on an X-ray. And again, that's the fourth red flag, knowing that this is an unstable pattern. The other thing that you could see on a CT scan is how far is your coronoid retracted. This can tell you that you might have difficulty in reducing this piece back. You can also pick up some other innocuous fractures of the radial head, which we might miss, and we may end up treating an unstable elbow. So when you have a simple dislocation, how do you differentiate from a terrible triad? So we talked about the ease of reduction. We talked about the stable arc. So if you have a dislocation which you have reduced and the patient has a stable arc from 30 to 130, then probably this is a simple dislocation and doesn't need any intervention. Most of the simple dislocations won't have fracture, or they may have just a minor fracture, something like this. But when you have a picture like this, don't ever leave the patient alone, because the results after non-operative management of a terrible triad are very poor, and this has been documented in the literature. So now we have an unstable elbow. Go back to your three columns, the anterior, lateral, and the medial column. And this is how I would look at it. The anterior column has a coronoid. So if I don't see a fracture on the CT scan, but the elbow is unstable, I would know that it's the capsule which is affected. So I would need some good sutures, or I would need some suture anchors. Now, in the X-ray or in the CT scan, if I see a small chip of coronoid and the elbow is unstable, I would again need some suture or suture anchors. However, if you have a very large piece of coronoid, something like this, then I need some screws or some plates. So this is my armamentarium for fixing the anterior column in a terrible triad. On the lateral side, if I see a radial head and which I feel I can fix, then I would either need screws or plate. So in a fracture like this, probably a plate would be essential. Or if I feel the radial head is comminuted, I would need a radial head replacement prosthesis. So for my lateral side, I need to keep a basic screws, radial head plates, and a radial head prosthesis on my operative table. On the medial side, almost always you need sutures or suture anchors. Now, you have decided that this is a terrible triad and you need to stabilize this. So what is the sequence? There is always a toss-up between fixing the anterior versus fixing the lateral column first. And where I trained and what I practice is this. I always try and get the anterior column fixed first. That means either the capsule, anterior capsule, or the coronoid. I approach this via a lateral approach, or if needed, a medial approach. We'll talk about it in a bit. Once I have fixed the anterior column, I would then look at the lateral column. So either fix the radial head or replace the radial head. And the third would be the medial column. Whether to fix it or not, we will discuss it in a moment. For me, the first incision is always the lateral incision, and that's the straightforward Coco's approach. For this picture, I thank Dr. Prashant Bhandari from Pune. This was a very nice picture of the lateral approach. Everybody does a radial head fixation. It's a similar approach. Ideally, you would see a specific plane because of the hematoma or the rupture of the capsule. So it's very easy to dissect. Once I get to the radial head, this is where the plan may change. Okay, I'm still trying to fix the anterior column. Okay, so if I go through the lateral approach, I look at the radial head first. If I find the radial head too comminuted, okay, so I know I'm going to replace it. So I will remove all the comminuted pieces. I'll continue with the lateral approach, and I would fix the anterior capsule, or if there is a small chip of the coronoid attached to the anterior capsule through the lateral approach itself. Okay. If I find the radial head comminuted, I'm going to remove it and replace it. But I find a very large piece of coronoid, which I think will need screws or plates. Then I'm going to go to the medial side, go through the two heads of the FCU, and fix the coronoid from the front. So again, whether I go from the lateral or the medial side, we would always fix the anterior column first. Now, we have opened up the lateral side. We find the radial head to be intact, so it's fixable. Now, since the radial head is fixable, you will not be able to approach the coronoid through here. So the radial head is fixable, so you will not be able to approach the coronoid or the anterior capsule through here. In this scenario, you need to make an incision on the medial side, go ahead, approach the coronoid from the other side. Now, coronoid, if it's a large fragment, then you could end up fixing it with a plate like this. Occasionally, you would end up fixing with screws like this. If it's a small chip, or if there's no coronoid fracture, but there is a capsular avulsion, then we end up fixing with sutures. I've used only once or twice. I've used anchors, but primarily we use pull-out sutures. We take good bites through the anterior capsule, drill holes through the ulna, and then pull it back. And then we go ahead and replace the radial head. On the lateral side, the decision is quite easy. So once you have fixed the anterior column, the capsule or the coronoid, you can either fix the radial head. In our series, we have done 11 fixations, or you could end up replacing the radial head, something like this. We have done about 11 patients. Again, for this particular radial head replacement slide, I would like to thank Dr. Prashant Bhandari from Pune. Once you have replaced the radial head, you have to always repair the lateral ulnar collateral ligament complex. And if the common extensor origin is avulsed, you need to put it back. Now you've fixed the anterior column, you've fixed the lateral side. Now you assess the anteroposterior stability again, and you range the elbow on table from 30 to 130. In this, after fixing these two, if you still find the elbow subluxating or dislocating, that is the time when you need to do the medial repair. This will be a picture that you will probably see when you do a C-arm imaging. You can see the radial head is behind the capitulum and there is a wide ulnohumeral gap. So this is the time I would go on the medial side and I would repair the medial collateral ligament. In our series of 5, we have ended up fixing only 5 of them. The medial approach is quite easy. You just have to take care of the ulnar nerve. From the same medial approach, you could fix the coronoid as well as you could fix the medial collateral ligament. Once you have fixed all 3 structures or the 2 structures, you close up. And this is what we follow in our practice. We immobilize the patient in an above elbow slab for 2 weeks. And beyond that, depending upon how compliant the patient is, we would end up giving him a sling or a splint. We start the range of movement at 1 week. We allow the swelling and any pain to settle down. We allow the flexion from 90 degrees to the mouth, so 90 to further flexion. At 1 week mark, we break the slab and allow 80 to further flexion, and so on. But by 2 weeks, we have removed this plaster, and then we would gradually increase 10 degrees every week so that the patient gets to extension by about 8 weeks. If you look at the books, a hinge knee brace is actually better, but I have no experience with a hinge knee brace. So these are our outcomes. The outcomes are not perfect because this is a difficult scenario. We had about 22 patients only over the last 7 years. If you look at it, there was a fixed flexion deformity of 20 degrees in almost all the patients. So you end up having some deformity because of maybe the anterior capsular scarring. Most of them end up getting a good range of function. Be alert, you may end up having a restriction of pronosupination, but this is again within the functional range of movement. We had 2 patients, despite repairing all 3 structures, still were subluxated at 1 week X-ray. What we did in those patients were we continued immobilization in about 100-degree flexion for about 4 weeks and then started our extension protocol.